Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of Tetralogy of Fallot designed for general pediatricians. We will work through 12 cases covering the diagnosis, what sets the severity, the origin of the murmur, hypercyanotic spells and how to break them, squatting, the chest radiograph, the electrocardiogram, clubbing, the genetics, life after repair, and the duct-dependent neonate. Let us begin. Question 1. A 5-month-old boy has episodes of turning deeply blue during feeding and crying. Each lasts 2 to 3 minutes and settles when his mother holds him against her chest with his knees drawn up. His weight has fallen from the 25th percentile at birth to 6 kilograms, just below the second. Saturations are 84% in air. There is a harsh ejection systolic murmur at the upper left sternal border, and the second heart sound is single. Hemoglobin is 168 grams per liter. What is the most likely diagnosis? Option A, large ventricular septal defect. Option B, Tetralogy of Fallot. Option C, total anomalous pulmonary venous return. Option D, transposition of the great arteries. 4 findings decide this case. Cyanosis that comes and goes rather than staying constant. Episodes ended by drawing the knees onto the chest. A single second heart sound with an ejection murmur high on the left. And polycythemia from months of desaturation. The correct answer is option B, Tetralogy of Fallot. Intermittent cyanosis relieved by a knee-to-chest posture is the hypercyanotic spell, and it belongs to this lesion. The single second sound means the pulmonary component is soft or absent, and the murmur comes from the narrowed outflow, not the septal defect, which is wide and silent. A large septal defect alone causes failure without cyanosis. Anomalous venous return gives constant cyanosis with congested lungs, and transposition presents with deep fixed cyanosis from birth. The raised hemoglobin confirms this is chronic. Question 2. A 4-month-old girl with known Tetralogy of Fallot attends for review. She is pink at rest with saturations of 93% and has a loud, long ejection systolic murmur. Her parents ask why she is not blue like another infant they met in the waiting room who has the same diagnosis. Which factor most determines the degree of cyanosis? Option A, size of the ventricular septal defect. Option B, extent of aortic override. Option C, thickness of the right ventricular wall. Option D, degree of right ventricular outflow obstruction. 4 findings decide this case. The same named diagnosis in 2 children who look quite different. Saturations of 93%, so most blood is still reaching the lungs. A loud, long murmur, which means flow is still crossing the outflow, and no spells described. The correct answer is option D, the degree of right ventricular outflow obstruction. The septal defect is large and unrestrictive, so pressures either side are already equal, and its size changes nothing. Outflow resistance, weighed against systemic resistance, decides whether blood goes to the lungs or across the defect to the aorta. Override and hypertrophy are consequences of the anatomy, not regulators of flow. And note the paradox. A louder, longer murmur usually means a pinker child because more flow is getting through. Question 3. A 6-month-old boy with Tetralogy of Fallot has a harsh ejection systolic murmur, loudest in the second left intercostal space, with a palpable thrill. A student asks what is actually generating the sound. What is the source of this murmur? Option A, turbulent flow through the narrowed right ventricular outflow tract. Option B, flow across the ventricular septal defect. Option C, regurgitation through the tricuspid valve. Option D, flow across the overriding aortic valve. 4 findings decide this case. An ejection quality, so the sound follows flow through a narrowing. Loudest high on the left, over the outflow tract. A palpable thrill, so the jet is fast. And systolic timing. The correct answer is option A. Turbulent flow through the narrowed right ventricular outflow tract. Turbulence needs a pressure drop across a narrow point, and in this lesion, that point is the outflow. The septal defect is wide and unrestrictive, so pressures either side are equal, and flow across it is completely silent, the commonest wrong answer. Tricuspid regurgitation is pansystolic and loudest lower down, and the overriding aorta is not narrowed, so it makes no murmur of its own. Remember this case. The next one depends on it. Question 4. An 8-month-old girl with Tetralogy of Fallot becomes progressively blue and agitated after a blood test. Respiratory rate 60. Saturations 65%. Her murmur, documented as loud earlier that morning, is now barely audible. What does the change in the murmur indicate? Option A, the spell is resolving. Option B, the ventricular septal defect has become restrictive. Option C, pulmonary blood flow has fallen sharply. Option D, aortic flow has decreased. 4 findings decide this case. Deepening cyanosis, not improving. A murmur that has almost disappeared within hours. Agitation and tachypnea, the picture of a spell. And the murmur tracks outflow flow, which the previous case established. The correct answer is option C. Pulmonary blood flow has fallen sharply. The murmur tracks flow across the outflow tract, so a fading murmur means that flow has collapsed. During a spell, the muscular infundibulum constricts and almost no blood reaches the lungs. The child is bluer, not pinker, so this cannot be resolution. The malalignment defect of tetralogy never becomes restrictive, and aortic flow rises during a spell rather than falling. That is exactly why she is bluer. The quieter the murmur, the sicker the child. Question 5. A 4-year-old boy with unrepaired Tetralogy of Fallot is observed in clinic. During play, he stops, adopts a full squat, remains there for about a minute, then resumes playing. His mother says he does this many times a day and has done so since he learned to walk. What is the principal mechanism by which this position improves his symptoms? Option A, it increases systemic vascular resistance, reducing right to left shunting. Option B, it decreases venous return from the legs. Option C, it increases pulmonary vascular resistance. Option D, it reduces cardiac output and oxygen demand. 4 findings decide this case. A self-taught posture, adopted spontaneously and repeatedly. It works within a minute, and the child then carries on. Hips and knees fully folded, and the shunt runs right to left across an unrestrictive defect. The correct answer is option A. It increases systemic vascular resistance. Folding the hips and knees compresses the leg vessels, and with systemic resistance higher, less blood crosses the defect to the aorta and more goes to the lungs. Squatting also traps desaturated venous blood in the folded legs, a recognized contributory effect, though the resistance rise is the principal mechanism. Raising pulmonary resistance would do the opposite, and resting alone is not why the posture works. Squatting is the child prescribing his own vasoconstrictor. Question 6. A 7-month-old boy is carried into the emergency department deeply cyanosed and inconsolable after a prolonged cry. Saturations 62%, heart rate 180. He is known to have Tetralogy of Fallot awaiting repair. His previously loud murmur is now soft and no cannula is in place. Which is the most appropriate immediate action? Option A, give intravenous furosemide. Option B, place him in the knee to chest position. Option C, start inhaled nitric oxide. Option D, give intravenous adrenaline. 4 findings decide this case. A spell triggered by prolonged crying, saturations of 62% with a softening murmur, no venous access in place, and known tetralogy, awaiting repair. The correct answer is option B. Place him in the knee to chest position. Position and calming come first. They need no drug, no equipment, and no access, and they work immediately. Furosemide reduces preload and deepens the spell. Adrenaline tightens the very muscle that is obstructing the outflow, and nitric oxide acts on vessels, not on infundibular spasm. If position fails, the latter runs morphine, then a fluid bolus, then phenylephrine or propranolol. The first treatment for a spell is free. Question 7. A 9-month-old girl has had cyanosis since early infancy. A frontal chest radiograph is obtained before cardiology referral. She is not in failure, and her chest is clear. Which combination of findings would you expect? Option A, cardiomegaly with increased pulmonary vascularity. Option B, egg on side appearance with a narrow mediastinum. Option C, uplifted apex, concave pulmonary artery segment, reduced pulmonary vascularity. Option D, snowman or figure of 8 appearance. 4 findings decide this case. Long-standing cyanosis rather than failure. Right ventricular hypertrophy from chronic pressure load. A small pulmonary artery, and reduced flow to the lungs. The correct answer is option C, an uplifted apex, a concave pulmonary artery segment, and reduced vascularity. Right ventricular hypertrophy lifts the apex clear of the diaphragm. The small pulmonary artery leaves the upper left border scooped instead of bulging, and underperfused lungs look dark, with sparse markings. Together, they draw the boot shape on a heart of normal size. Cardiomegaly argues against the diagnosis. The egg on side belongs to transposition, and the snowman to anomalous pulmonary venous return. Question 8. A 2-year-old boy with unrepaired Tetralogy of Fallot has an electrocardiogram performed before surgery. He is otherwise well, with saturations of 85%. Which finding would you expect? Option A, left axis deviation with left ventricular hypertrophy. Option B, superior axis with left ventricular hypertrophy. Option C, a normal ECG for age. Option D, right axis deviation with a dominant R wave in V1. 4 findings decide this case. Chronic pressure loading of the right ventricle, 2 years old, past the newborn period in which right dominance is expected, unrepaired disease, and no left-sided volume load. The correct answer is option D, right axis deviation with a dominant R wave in V1. Chronic pressure loading thickens the right ventricle, giving a tall R in V1 and V2 with deep S waves in V5 and V6. Right-sided dominance is normal in the newborn and fades through early childhood. It is the whole pattern with the clinical picture, not age alone, that marks it as pathological here. A superior axis with left ventricular hypertrophy is the signature of tricuspid atresia, and left-sided patterns have no place in this lesion. Question 9. A 3-year-old girl with unrepaired Tetralogy of Fallot, whose family declined earlier surgery, is seen in clinic. Her fingertips are bulbous with increased nail curvature. Resting saturations are 78%, hemoglobin 192 grams per liter, hematocrit 0.58. What does this finding indicate? Option A, chronic hypoxemia. Option B, iron deficiency. Option C, infective endocarditis. Option D, pulmonary hypertension. 4 findings decide this case. Bulbous fingertips with increased nail curvature, saturations of 78% at rest, a markedly raised hemoglobin and hematocrit, and years of unrepaired disease. The correct answer is option A, chronic hypoxemia. Clubbing is a bulbous tip, increased nail curvature, and loss of the nail fold angle, and it takes months to develop, so it reports long-standing desaturation. The polycythemia is the same story told in the blood. Iron deficiency does not cause clubbing, and in cyanotic disease it hides behind a raised hemoglobin, which is why it is screened with ferritin